like to welcome our first speaker, Dr. Harry Auster. He is the director of the Human Genome Program, Human Genetics Program at NYU Medical School. He is a professor of pediatrics, pathology, and medicine there. And he has a wide range of interests which he's pursued in his laboratory. He's worked on the genetics of prostate cancer and other forms of cancer. He's worked on genetics of ancestry, particularly in Jewish and Latino populations. He's worked on the genetics of male sexual development. And he's been very involved in issues involving the fair use of genetic information. And in that capacity, he's been an advisor to the National Institutes of Health. He's been an advisor to the Defense Department and the New York Bar Association here in New York, in which he's been involved in every piece of legislation that's pending or enacted that has to do with genetic testing, with reproductive technology, and human cloning. So welcome, Dr. Auster.
So I'd like to thank Paul Hoffman and his fellow organizers of Big Think for inviting me to participate this evening as Francis Collins' understudy. This invitation has left me wondering whether there might be an NIH directorship in my future, or whether I'll be left with the happy fate of being a medical geneticist, free to pursue my own research leads. There are three areas that I currently explore. The first is the genetic control of male sexual development. Normally, a switch on the Y chromosome turns on a pathway that causes half of us in the population to develop testes, male reproductive structures, and to develop as men. But this switch, or its downstream relays, may go awry, causing affected individuals to develop as women or to have ambiguous sexual development. These people with disorders of sexual development present the experiments of nature that we geneticists so value because they represent an opportunity for understanding the whole cascade of genes in the male sexual development pathway. In my lab, we've recently identified one of these regulatory genes for male sexual development, and we think that it is not a relay for the master regulator. Rather, it regulates the on switch for the master regulator. We studied the populations of Jewish and Hispanic Latino people. Together, these groups comprise 12 and 20% of the population of New York City. We're tracing the Jewish diaspora back and forth across the Mediterranean basin, into Europe, and into the New World. Jews form their own distinctive genetic clusters, with each group of the diaspora forming its own subcluster. Puerto Ricans and Dominicans are, for the most part, the variable descendants of Europeans and Africans, whereas Mexicans, Ecuadorians, and Colombians are the descendants of Native Americans and Europeans. We're using methods that recognize this admixed ancestry to map genes for traits, such as susceptibility to breast cancer. In fact, my NYU collaborators and I are working to develop predictive genetic tests for breast, prostate, and prostate cancers, as well as melanoma, envisioning a day, perhaps 5 years hence, when it will be possible to perform a test in which the results will be reproducible and meaningful. If we thought that the tests that are offered by direct-to-consumer genetic testing companies were valid, then we would use them at our cancer genetics risk evaluation program, where we see nearly 1,000 people each year assessing their risks of breast, ovarian, and colon cancers. When a new genetic test is introduced into clinical practice, we're looking for three things: analytical validity, clinical validity, and clinical utility. The tests that are performed in my clinical genetics laboratory and in the other laboratories that I use to assess the risk for my patients at NYU meet all of these criteria. Let's look at each of these in turn. Analytical validity is the ability of a test to accurately and reliably measure the genotype of interest. For many DNA chips, the call rates are in the range of 98 to 99.9%. That sounds great, but let's throw in some numbers. This means on a DNA chip with 1 million probes, 1,000 to 20,000 results are being missed. That's okay in my research lab, but it sure isn't in my clinical lab, where I have to guarantee to the patients and to the Department of Health that I can provide complete results to every patient. Now let's throw in the recent computer software, and we learned from Shrikant Mani, who runs the DNA chip core facility at Yale, that the false positive rate is 1%. This is a false positive rate anywhere on the chip, not in the probe for breast cancer or type 2 diabetes. My patients in the Department of Health would say, well, Dr. Auster, that just isn't good enough. So what about clinical validity? This is the ability of a test to detect or predict the associated disorder. It must be great, no? Why else would these direct-to-consumer companies be offering testing to consumers? Jeffrey Drazen, the editor of the New England Journal of Medicine, has written, even the ardent proponents of genetic susceptibility testing would agree that for most diseases, we are still at the early stages of identifying the full list of susceptibility-associated variants. We know from research studies that most common diseases, diabetes, various cancers, and heart disease, are caused by multiple gene variants acting together with environmental factors. The studies that are now identifying these factors and their interactions are only now being conducted, and their validation for clinical use will come later. As you will hear from a fellow panelist, no two companies can agree on her risk of disease. Bloggers who have used direct-to-consumer genetic testing have written about how their diabetes or colon cancer was not predicted by the DNA chip. Ken Offit, the head of cancer genetics at Memorial Sloan Kettering Cancer Center, has written, the companies often state that the services offered are not medical tests, but they are provided for informational purposes only. But seriously, folks, if you learn that you are at increased risk for heart attack or colon cancer or type 2 diabetes, wouldn't you want to discuss this with your doctor? And wouldn't you feel rather foolish when he said, but seriously, Ted, let's not make too much out of this? Or would he start ordering tests, a stress EKG, colonoscopy, a glucose tolerance test, to follow up on the false positive results that are the bane of physicians' practices? This raises the third issue of clinical utility, or the balance of associated risks and benefits. Jeffrey Drazen from the New England Journal has written, this is the arena in which there are virtually no data on the health impact of genome-wide analysis. There are very few observational studies and almost no clinical trials that demonstrate the risks and benefits associated with screening for individual gene variants, let alone testing for many hundreds of thousands of variants. And what might we do, and what might those recommendations be? Lose weight, eat better, stop smoking, exercise more? Who needs a $1,000 genetic test to tell her to engage in lifestyle changes that will have broad health effects? Suppose she learns she is at increased risk for breast cancer, as women who are BRCA1 carriers do. Would she take drugs that would put her into menopause or have her breasts removed to lower the risk? Or would she just worry her way from one mammogram to the next? So what can we do now that is reasonable? Get diagnosed if you have a genetic disease. Get treated and learn about it. Knowledge is power. Learn about your family history. If based on your family history, you are at high risk for colon cancer, heart disease, blood clots, or a host of other conditions, consult with a medical geneticist. There may be a specific genetic test that is appropriate for you. Get carrier testing before marriage, before pregnancy, during pregnancy. Get the other tests that are appropriate for people in your stage of the life cycle. Learn your risks and act. You don't need a $1,000 genetic test to spur you into action. Now, the purveyors of direct-to-consumer genetic testing would say that this is the old-fashioned Neanderthal Luddite practice of medical genetics. But I would beg to differ. We medical geneticists and genetic counselors are the age of progress of genetic discovery. We have reinvented our profession many times, and we are leading the way to discovering the analytical validity, the clinical validity, and the clinical utility of new genetic tests. We admire the community activism that brought us new treatments for HIV/AIDS, expanded genetic screening for breast cancer via mammography, and validated new genetic testing for many conditions. We want to build a bridge to somewhere. We are looking forward to that day when a 61-year-old man walks into our office with a pill-rolling treamer, and we can insert his DNA sequence microdisc into our genetic risk reader, and it will state with high likelihood that he has Parkinson's disease type 7. Moreover, it will tell us that he would benefit from treatment with drug C because of his personal risk-benefit genetic ratio. That day is not far off, and it will be coming one disease at a time. In the meantime, I fear that the purveyors of direct-to-consumer genetic testing, with their faulty claims, will scare away our patients and betray the public's trust in medical genetics. Thank you very much for listening.